Pain, that medically elusive evil. What about changing the focus from controlling pain to understanding pain as more than a symptom? Can pain be cheated? My name is Dr. Dean, chiropractor and physiotherapist. My goal is to reframe how medicine understands pain to improve care. This podcast series is dedicated to a same-day conservative treatment for low back pain. This podcast has a companion published article number 21. Welcome to the Pain is Not the Only Problem podcast. Article 21. Pain is not the only problem. First encounter. Part 2. These articles intend to reevaluate the prevailing clinical practices thought to manage low back pain, submit and debate novel low back pain contributors and mechanisms, meet patient expectations and satisfaction and clinically meaningful results, recommend a conservative non-surgical course of care to override pain instantly and restore ADLs and patient confidence on the first visit at low cost. When low back patients come to the doctor's office, they make one of two statements. Doctor, when I fill in the blank, I feel pain. Or, doctor, I feel pain when I fill in the blank. Both statements disclose a feeling of pain and a description of a function that is associated with the pain, but possibly not the cause of the pain, rather an association with an insufficiency of some kind that has been undiagnosed. The pain is not causing the insufficiency, so it can be ignored, while the functional problem is explored. This does not mean that we are going to ignore palliative care. Functional insufficiency has been already discussed as a presentation of spinal instability and many other contributors. Not yet discussed are the topics of undiagnosed, misdiagnosed patients and untreated, mistreated patients. The undiagnosed category includes patients that have not sought out care for many possible valid, equal reasons, or patients, quote, stuck in the system, and patients in the wrong doctor's office. What does that mean? Misdiagnosed patients worry me the most because a doctor has likely sold them on a diagnosis that ensures a reason to start treatment, and the doctor can sign them up for treatment within their office today. Misdiagnosis includes the following: hastily diagnosing without a complete clinical picture, a rushed diagnosis using the words such as possibly in that category, or 2, pressuring the patient without discussing the clinical reasoning for the diagnosis, or 3, incomplete diagnosis that focuses on the clinician's favorite diagnosis, and 4, scaring the patient. In all cases, the doctor should never hold up a picture and blame everything on disc herniation or protrusion, a pinched nerve, spinal canal stenosis, degenerative changes, or subluxation. Pictures can't demonstrate non-traumatic low back pain function. Pictures cannot demonstrate pain, for that matter. Steele et al. 2014 offers us this. Despite the prevalence, no specific cause can be found for almost 85% of chronic low back pain cases. What are your attitudes at the first encounter? Keefe and Wren 2013 offer us this, a growing body of research showing that interventions designed to enhance positive adjustment can benefit patients suffering from persistent pain. We need to pay more attention to the role that positive adjustment factors such as optimism play in the pain experience. Focus on their strengths, sources of resilience, and best possible self. This is a list of suggestions for the patient's first encounter. Number 1, create a strong projected desire and ability to treat the patient quickly at low cost. 2, ask for and listen to the patient's expectations and psychosocial limitations. 3, inquire about patient knowledge of the human anatomy and function specifically related to low back pain. And 4, patient self-sense of historical experience with sports and activities, And 5, offer access for anytime support. And finally, 6, don't rush anything. The patient's framework is different than the doctor's framework on the first encounter. The patient wants the doctor to be on time, to make them feel comfortable, to be professional, and to make a positive connection. The patient wants the doctor to factor in everything that is important to resolve their low back pain, make an accurate and complete diagnosis, explain the diagnosis, and offer treatment options that meet their personal values. The patient wants to see confidence in the doctor and a promise to treat them with good care and to get better quickly. The doctor's framework is different. Since the practice is a business, it is likely based on volume and billability. The doctor must practice within the confines of the third-party payer demands and restrictions. The doctor gets overbooked, the doctor gets behind, the doctor gets stressed, and takes shortcuts at the first encounter. The doctor utilizes personal bias and a cookbook approach to care, diagnosing from a list of favorites, and rushes the diagnosis explanation. The doctor does not offer or administer a report of findings. Patients are not offered treatment options. Patient risk increases, trust is lost, and without any promise or guarantee. The patient is kept in the cycle of endless revisits to pay overhead, what I call kicking the can of the patient's health care. On the first encounter, the clinician should be asking broad, nonspecific, yes/no questions to first rule out 911 or red flag concerns and to save time. There are excellent intake forms backed by significant research that can aid the clinician's efficiency by simply scanning the form. The clinician should be sure to discuss any overlooked everyday type movement deficits, explain how improper footwear and postures are choices and not disease, explain how smoking, alcohol, and diet prevents low back pain healing. The first encounter physical exam should include basic non-orthopedic physical tests. These tests should be listed and performed in order with a pass-fail checkbox. This exam should take no more than 5 to 7 minutes. If the patient fails the spinal stability skills performed first on the list, stop the physical exam, prescribe spinal stability re-education for 3 to 4 weeks, then have the patient come back. On the follow-up, retest the spinal stability skills. If the patient passes, continue to perform the remainder of the physical exam. If the patient passes the spinal stability exam, the pain will have likely diminished or resolved anyway. If the patient has experienced a critical level of low back pain, read all of my articles in this series. Which treatment milestones do you use to determine patient outcomes? I use these improvement milestones in my practice: motor, symptoms, ADL, RTP, hobby interest resumed, social reintegration, emotionality, depression, optimism, specific personal goals, and of course I ask the patient, did I meet your expectations? It is during the first encounter that the clinician can do the best work because pain is not the only problem. Thank you for joining me today. Let's advocate for improved patient satisfaction and for the profession. Let's demonstrate a cross-cultural willingness to strengthen medicine. Thank you.